How many times have you gone to admit a patient and you find that they have a wound that looks like this, or maybe even like all of these ones? Managing chronic pressure ulcers, sacral decubitus wounds, oftentimes with associated chronic osteomyelitis, is one of the most complex and perhaps frustrating conditions that we have to deal with as internists. Sometimes it feels like we're just the middleman trying to coordinate care, all the meanwhile getting ping-ponged back and forth between various subspecialties. Say the patient comes in septic or has signs of osteomyelitis, so you decide to consult orthopedic surgery for a possible bone biopsy, but they say, no, it's not indicated at this time, it wouldn't change management. You consult ID and they say, no antibiotics are indicated because this is a chronic osteomyelitis and we're not going to treat this unless there is wound flap or wound closure. Then you consult plastic surgery and ask them when a flap can be done. And they say, patient is not optimized enough for this surgery. It's going to take several months of doing lots of rehab and things like this. And so basically nothing can be done at this time. All the meanwhile, you're running around like a chicken with your head cut off and you're like, what am I doing for this patient right now? They're just sitting in the hospital here and I've called a bunch of consultants and we're just letting this wound fester here. That's what it feels like. As hospitalists and internal medicine doctors, there really is a lot of things that we can offer these patients and make a big difference to them, especially as they are a particularly vulnerable population, being that many of these patients are bedbound, they need a lot of social support at home, they've had severe spinal cord injuries that have limited their mobility and things like that. So there really is a lot of good that we can do in terms of coordinating their care. So last night I was working on this dot phrase, which contains basically my current understanding of how we can treat these patients or help these patients. And so it starts off obviously with chronic pressure ulcer, and we're going to go through and mark what stage it is. So obviously if you go on Google, you can look up the stages 1 through 4 and see what stage it is. But typically when they are coming in with bad wounds looking like that, it's at least stage 3 or stage 4, which means there's muscle and tendons or bone exposed. And so the first thing that we really can do is work on optimizing them for a potential surgery or flap closure in the future. So all of these require different specialties or ancillary services that we can get involved. So right away, I would get physical therapy and occupational therapy involved to assess the patient's mobility, to do pressure mapping. So say they're a spinal cord injury patient and they are on a wheelchair, or even if they're just lying in bed, they will be able to provide durable medical equipment recommendations that the patient can go home with to reduce pressure off that injury and really optimize it for healing. You also definitely need to consult the wound care team for wound care recommendations and possible debridement. Anytime that there is necrotic tissue, it needs to be removed. And if it is more extensive, this may not be able to be done at the bedside, and you may need to consult surgery to do it in the operating room where they can give the patient sedation and anesthesia so they don't feel it, because if it's extremely extensive, it's going to be too painful to do at the bedside. Next, you should always consult a dietitian to optimize their nutrition, because this is a huge factor in the ability for the patient to eventually heal this wound. And a couple things that the surgeons and generally the dietitians like to check is pre-albumin and albumin to assess the nutritional status. So the goal pre-albumin is greater than 15 and the albumin is greater than 3. And also considering vitamin C and zinc supplementation, which is a very common practice, which is thought to promote healing. Although generally speaking, the evidence for this practice is quite poor, although it's not really going to hurt, so you might as well do it in most situations, in my opinion. So going back to the pre-albumin and albumin goals of greater than 15 in albumin, one thing to consider is this patient eventually going to need like an NG tube or a PEG tube in order to get that adequate nutrition? Some of these patients can't feed themselves well, or they have some other issue impacting their nutrition. So you really need to consider, do they need enteral feeding down the line? The other thing, you could probably order right away is the Boost oral supplements, just to really up their protein intake, and that will really help kind of boost their albumin levels as well. Now let's move on to talking about possible infectious complications that could happen, because all the time you're going to be coming in and admitting these patients, and people are going to say, hey, patient is tachycardic, they're febrile, they got a mild white count, they're septic because of this pressure wound that looks horrible. There's like yellow, purulent looking material coming out of it That's obviously the source, right? We've got an infected pressure sacral decubitus ulcer. So the first thing to note is that typically speaking, pressure ulcers rarely tend to get infected and be the cause of sepsis. I was looking on UpToDate, and I think I saw at one point that there was some study that it was less than 20% of the time the cause of sepsis is from the sacral wound. And then various other attendings have told me that these kinds of pressure ulcers rarely cause true overt sepsis. So instead, if the patient is septic, you want to first assess for other causes, such as UTI or pneumonia, which are much more common causes of sepsis in this population. The other thing that you really should get is ESR and CRP, which will help you assess for the risk of a necrotizing fasciitis or acute osteomyelitis. Sometimes these patients can have the chronic osteomyelitis, but they can also develop acute on chronic osteomyelitis. And then subsequently, if you still have high suspicion for a skin and soft tissue infection, for example, it really does look like there's a cellulitis going on there. It's not just the ulcer with the granulation tissue inside, but there's also the surrounding erythema and warmth that would suggest cellulitis. Then you would start antibiotics. And what you would do in this situation is consult acute care surgery for more urgent source control. So they would take them to the operating room, do a debridement of all the necrotic tissue. And also you want to ask them for a deep tissue biopsy because that will help guide your microbial cultures eventually. A lot of times I've had patients go to the OR and then we never asked for that deep tissue biopsy. Eventually we get ID on board and they're like, hey, what? We have no culture data. This sucks. Like, how are we going to figure out a good plan? So always good to ask those surgical services to get a deep tissue biopsy. And you would start them on very broad antibiotics, actually. Typically for just run-of-the-mill cellulitis, you could start them on cefazolin or vancomycin if there's concern for MRSA. But for these patients, these wounds are very much polymicrobial. It's whatever is getting into the skin there. And these patients come to the hospital all the time. So they're going to have Pseudomonas growing in there half the time, MRSA, things like that. So you want to start them on Vanc, Cefepime, and Flagyl. And this is per the UpToDate recommendations for infected pressure ulcers. Now, if you do suspect necrotizing skin and soft tissue infection, such as necrotizing fasciitis, don't forget you can calculate the Lurinex score if you are not sure about how high of a degree of suspicion you should have. But again, you should consult acute care surgery and you should start Vanc, Zosyn, and clindamycin. This is the regimen that we typically use for a necrotizing fasciitis because it's broad spectrum, and the clindamycin also deactivates some of the toxin that's produced by the necrotizing organism. And finally, if acute osteomyelitis is suspected, then obtain an MRI and consult IR for bone biopsy. They're generally preferred, at least in my institution, over orthopedic surgery, mainly because they can do a little bit of a better targeted approach to obtaining that bone biopsy. And also they have more scheduling availability compared to orthopedic surgery. One thing that I will want to note is that if somebody has long-standing chronic osteomyelitis, antibiotics are typically not indicated if the wound is to remain open. If the patient has an active skin and soft tissue infection, such as cellulitis, then a typical 5 to 14 day course would be indicated. And then if you look on UpToDate, they will occasionally suggest a full 6-week course if the patient did undergo surgical debridement and it appears that they are responding really well to the antibiotics and it's healing, then you can consider 6 weeks, but I would definitely touch base with ID about that. And eventually, once the patient gets a surgical flap and a wound closure is achieved, then a 6-week course of antibiotics is typically prescribed. So this is really our end goal. We want to get that surgical flap by plastic surgery. Once that's done, we can get 6 weeks of antibiotics and clear that osteomyelitis. But again, it all comes down to optimizing the patient for that eventual flap procedure. And so again, this is all going back to optimization. So these red ones, I'd say, are optimization, and the blue ones are infection control. So if the wound is within 6 centimeters of the anus, or if it's frequently soiled from fecal incontinence, which can be quite common in this patient population because they often have spinal cord injuries, they have no control over their bowel or bladder, you should consult colorectal surgery for a possible fecal diversion. So they may need a colostomy to make sure all of that stool stays away from continually contaminating their sacral ulcer wound. If they have ongoing urinary incontinence, you should consider consulting urology for a urinary diversion. Maybe they need an ostomy for that too. Maybe they need suprapubic catheterization, which is very common in these patients anyways. So that's definitely something you need to think about. And then if the pressure ulcer is stage 4, you really should consult plastic surgery prior to discharge to determine if surgical intervention is warranted in the acute setting. Now, most of the time, acute surgical intervention is not going to be warranted because these patients need to have infection treated. They need to have all the, PT, OT evaluation, optimization stuff all in line. And then they have to wait, 6 months for some signs of healing to happen before they're going to decide to flap and cover that wound. But there are some situations where a patient comes in with an acute pressure ulcer and they have a rapidly reversible etiology for that ulcer. And in that case, it may be warranted that they can get a procedure while in the hospital. Okay, on discharge, everybody should receive a wound care clinic referral, at least at my institution. This is actually better than a plastic surgery clinic referral because at the wound care clinic, they're experts in the wound care. They've got a lot more equipment, such as Hoyer lifts and things, to help the patients mobilize a little bit better. And plastic surgery also goes to that clinic and follows a lot of the patients that are there. And finally, preemptively, I would probably just consider ordering home health PT, OT, and nursing. You should order DME for a low air loss mattress, which is shown to be the best kind of pressure relieving mattress for reducing pressure ulcers. Also getting a Roho cushion. And then frequent turning, at least Q2 hours. The evidence for it is really not that strong, but it's not going to hurt, right? You want to turn them frequently, make sure they're not getting too much pressure buildup in one area. And at the very beginning, at least until the wound care nurse drops the recommendations, order some BID moist to dry dressing changes, which is just going to help exfoliate that area and just get rid of all that necrotic tissue slowly and just do some microdebriding essentially, just to help get that wound healing process started. So anyways, that is my basic approach at this time to managing chronic pressure ulcers and sacral wounds. As you can see, it really is a very complicated subject and you have to get a lot of different people involved. But if you can really get the ball rolling for patients right away once they get admitted to the hospital, I feel like you can really make a big difference for not only the patient, but also all those specialties who are obviously a little bit annoyed that they get consulted all the time and there's nothing that they can do at that time, right? This is definitely an area that as hospitalists, we can really make a big difference. And then, as I mentioned, this is still an area that I am still learning about and researching about. And I actually just joined a QI project for pressure ulcers management at our hospital. So hopefully I'll continue to learn more about it through that process. But if you have any tips or tricks yourself, or think that there's something that should be added to the stop phrase, or any other ideas that you have, please leave them down in the comments down below. It would be very, very helpful, not only to me, but anybody else who's watching this video. And again, I hope this was helpful. Thanks again for watching, and I'll see you in the next video. Peace.